Yes, you can introduce, yes.
We can start. So thank you very much. Today we have a new lecture. Professor Nicolas Bonnevialle will give us the lecture, very important. It's about traumatology and fracture of the upper limb, and mainly he will speak about humeral fracture. It's an important topic. So thank you, Nicolas, again to be with us and to give a lecture and to help our Myanmar friends. Thank you very much to give this lecture. Now you can share your screen and start. Thank you, Nicolas.
Okay, thank you. Hi, everybody. So we're gonna start, and the question today is the management of proximal humeral fracture. We're gonna speak about fixation and non-operative treatment, but in Europe we have an access to shoulder replacement as well in these situations. So if we look at the epidemiology, we can see that proximal humeral fracture is really big issue in the next few years, especially because the patients are older, and if we look at the rate of proximal humeral fracture, it's at the third row, just after proximal femoral and wrist fracture. So it's a really big deal in the next few years, and it will really increase if we look at this data from the Finland Epidemiologic Center, and it will increase in the next years. So the question of the proximal humeral fracture are turning around 3 points. The first is, do we need to operate this patient or not? The second question is how to operate this patient with fixation or replacement, but maybe we'll start just with fixation today. We are facing in this situation to 3 different problems. The first one is osteoporosis. We can say that the patients are elderly, and so there are a lot of osteoporosis. The question is the same if we compare to a proximal humeral fracture the same question than proximal femoral fracture. Do we need can we fix that, or is it efficient? The second question is avascular necrosis. We can say here on this picture, and the last one is malunion or non-union. And facing the 3 points, we are 3 strategic errors that we can do. It's evaluation or misunderstanding of the patient, the fracture, or eventually and the surgical principle. So 3 different strategic errors: misunderstanding of the patient, the fracture, and the surgical principle. So we have 2 types of patients. The first one, the young patients, where we sustain a high energy trauma, but the bone is good and is really ready to corroborate to rehab. The second one is an elderly patients with a minor trauma and a huge osteoporosis, and with probably a reduction of motoric coordinations, and that means that you will not really corroborate for rehab. And these 2 examples here of how the quality of the proximal humeral the quality of the bone of proximal humeral can be. So the young patient has a really good quality, and the elderly has a bad quality. And one more time, 2 kinds of patients. One is ready to corroborate. The other one is not ready. Just looking at that, the age is not always a good option to evaluate the quality of the bone. And we know that some patients in Europe, especially here in Europe, we don't really can evaluate the patient according to the age. So we have to look at the X-rays. We need to look at the comorbidity of the patients, and we are able to evaluate the bone during in pre-op according to these different informations. Second point is the fracture. We have to understand the fracture, and Nier described in 1980 a different pattern of the fracture, and you can see that he divided the proximal fracture in different fragments, as you can see, 1 fragment, 2 fragments, 3 or 4 fragments. It depends on the piece of bone. And if you look at here, this picture, we can see that there is 1 fragment, which is the head, the cartilage part of the proximal lumbar fracture. The second one is the lesser tuberosity. The other one is the greater tuberosity, and you have the shaft. Nier describes this classification, which is really efficient to describe the different type of fracture, but to be true, he never describes this fracture. He just used a very old concept, which is a Codman concept. This is just for the story. And other authors describe something which is quite the same, just with a different approach, which is a Lego concept from Hertel. But if you look at the draw and the picture on right-hand side, you can see that this is more or less the same. You've got a fragment, which is a piece of bone with the cartilage and the lesser and greater tuberosity, and you can find the different type of fracture when you look at the X-rays. So the fracture, there is, according to me, 2 different type of fractures. The first one is undisplayed fracture. The undisplayed fracture, you can see that you have 4 fragments in this example on left-hand side, but you have to keep in mind that if it's non-displayed, and if you look at the data and the paper from Nier, it described that the displacement between 2 fragments is 1 centimeter of in between, and a displacement of more than 45 degrees between 2 fragments. So it's a huge displacement here, and even if in the past we base our indication according Nier criteria, today we think that it's too much. So according Nier, an undisplaced fragment is a fragment which is separate from another, or less than 1 centimeter, or a modification of orientation less than 45 degrees. So it was the criteria of Nier. Maybe then today we can narrow the displacement in between two fragments. So first part, undisplaced fracture. If you look at the draw, you can see that the shaft will immediately medialize because it's pulled by the lat dorsi and the pec major and other anterotators. The lesser tuberosity will medialize as well because it's pulled by the subscapularis muscle, and the greater tuberosity will be pulled backwards in the back and in medial as well, because it's pulled by infraspinatus and teres minor. So all this displacement you can see on the draw. The second type of fracture is a displaced fracture, and you can see that you can find 1, 2, 3, or 4 different fragments. So according to us, 85% of fracture are undisplaced and the other are displaced. So if you got a one-part fracture according Nier is an undisplaced fracture. You have 4 fragments, but it's not really displaced each other. If you look at here, you can find that this fracture is complex because there is different fragments, but they are undisplaced. And in this case, the best option is a non-operative treatment. So don't touch this patient. Just pull this patient if you are allowed, or if you got an access to this kind of immobilization. Why? It's much better than a sling, which is in anterior rotation, because you are at risk to create a malunion in anterior rotation. If you look at what happened in anterior rotation sling, you will see that the shaft is turning medial. So, and this part is stuck in this position. So you are at risk to create a malunion in anterior rotation. So it's better to put a pillow between the body and the arm, just to neutralize the anterior rotation trend of the shaft. But of course, in many cases, if you don't have an access to neutral pillow, you will use just a sling. In this situation, how long will you immobilize the patients? Well, it's better to immobilize only 3 weeks. It's much better than more. Why? Because in 3 weeks, you will get a soft union, but you will get an union which is enough just to start rehab. How to start rehab? You will ask the patient to do pendulum exercises and passive range of motion recovery. So 3 weeks, pendulum exercises, and passive range of motion recovery. It's better to use this pillow, but if you don't have an access, use just a sling. But in other situation, as you can see here, you will you should stabilize reduce and stabilize the patient. So it's much better to rebuild the normal anatomy of the proximal humerus. Otherwise, you will have a stiff elbow, stiff shoulder, and you will have because of malunion, and you will have a necrosis of the proximal humerus. So why you will have a proximal humerus necrosis? Well, because it's really complex. But if you look at here on left-hand side, you can see that the arteries distal of the proximal humerus are really involved in the fracture, especially because there is here an arc, which is an artery here at the around the head, which is at risk to be involved in the fracture, and so you will get a necrosis. There is different aspect of the fractures and will probably be with a higher risk of necrosis. The first criteria is the calcar. The calcar is the same that you can find in proximal femoral fracture. It means that if your calcar is here long, it's I mean it's short on the head but long on the shaft, it's at higher risk to necrosis than if you have a long calcar on the head and short on the shaft. Why? Because the artery arc here is in the inferior capsule. So if the shaft is long, it means that the capsule is not involved, and so the artery arc is not involved. But if the calcar is short, it means that probably that artery arc is involved, and so you have a higher risk to have a necrosis. The second point is the complexity of proximal humeral fracture, and more part and more fragment you have, a higher risk of necrosis you will get. So the criteria of necrosis is a calcar here, and it was defined as 8 millimeters. If you have less than 8 millimeters, which is the point, insertion point of the capsule, inferior capsule, it's an higher risk to have a necrosis. What is the prevalence of humeral head necrosis? If you have 3-part fracture, it's between 12 and 25%. If you have 4-part impacted valgus, the fracture is around 26%. And with 4-part totally displaced, it means that there is no contact bone. It's around 60%. So it's an information that you can have, keep in mind, and you can provide to your patients. More fragment and more displaced fragment you have, higher risk of necrosis you will get. If you have an access to CT scan, it's much better to understand the fracture. And in this example, you'll have a 3D reconstruction of proximal humeral fracture. You can see that the greater tuberosity, which is here, and lesser tuberosity, which here, are still in line with the shaft, but the head is dislocated here. So hopefully, in this case, we are really lucky because we just reduce with external maneuver the head, which replaced in the right position. And this is a CT scan post reduction, which is really good. You can just see that there is a really small malunion between the proximal humerus and the shaft, because the groove here is just mal-rotated, related to the groove on the shaft, which is a bicipital groove. So there is a slight displacement, but the patient was never operated and it was just reduced, and we were lucky in these situations. The third point is how to fix these patients. Well, the proximal humerus is quite different in terms of fixation and not in terms of evolution in post-op, but in terms of fixation, it's quite different if we compare to a hip, because there is all hip fracture loaded in vertical plane, but in proximal humeral fracture, all the loaded are horizontal, and all the muscle are pulled in medial. So we have to counteract these pulling forces in medial. So this is a hip, and it's quite different from a biomechanical point of view if we compare hip and proximal humeral fractures. So if you look at here this biomechanical model, you can see that the eggshell model is really interesting. This part looks like a head, a cartilage part, and this part is a fracture line of the anatomic line. So this part could be the head, and this part could be the greater and lesser tuberosity. And the eggshell model, which was developed by Hertel, which is a Swiss guy, show you that if you fix greater and lesser tuberosity, you will support the head. You don't need to fix the head. You need to fix really properly greater and lesser tuberosity. This is a key. It's a mechanical support and it's a vascular support of the head. So how to fix greater and lesser tuberosity, how to fix the head? You have different options. Of course, maybe the last one is not really available or easily available for you, but you can use osteosuture, you can use percutaneous pinning, you can use intramedullary nailing, plate fixations. And if you look at all these devices, you can see that some of them are simple, others are really complex to use and probably not available. I will just show you what we still use from time to time, which is a low-cost material and a really efficient technique just to fix proximal humeral fractures. You need just a drill from 3.2 to 6 millimeters. So you will increase with the drill bit a hole in the shaft. You will see in a few moments. You will need K wires like you use for pediatric fixation. So K wires here, you can have a double banded K wires. You will it's homemade. You need a non-reservable suture, AV suture, and if you have cannulated screws, but it's not always necessary. This patient is, as you can see, in mid-shears position. Just you flex the trunk of 20 or between 20 and 49 millimeters, and you will use a C-arm and identify where is the entry point at the V deltoid insertion on the lateral part of the shaft, and you will identify where your K wire will be pushed in the shaft, and you will identify here the superior approach, because from time to time you need to open and to properly reduce greater and lesser tuberosity. So if you look at here, this proximal humeral fractures, there is a displacement of the shaft related to the humeral head, and we want to fix the shaft just in the right position under the greater and lesser tuberosity. So with a C-arm, you will identify where is the V deltoid insertion, because the deltoid, you can see the deltoid on C-arm. You can see where is the shaft is thicker, if it's and so it's really easy to identify the entry point. Now, then you will just open the skin. You go straight to the shaft. You will use two retractors, one in the front, one in the back. Be aware that in the back there is a radial nerve, so be aware that you will not injure the radial nerve. Then you open the shaft with drill bit from 3.2 to 6 millimeters, and you will push inside the shaft 3 or 4, if you are able to do at least three K wires, as you can see or in this picture. There is two options at this point. The first one is to reduce with the K wire the head, but it's not always possible because it's really impacted in the greater and lesser tuberosity. And if you are lucky, you can do. If you're not lucky, you will just open in superior approach. Use a spatula, for example. In this situation, you will see that there is a valgus impacted. So you will just push on the humeral head, then push the greater and lesser tuberosity under the humeral head, and the K wire then push in the head just to temporarily fix the head. If the patient has a huge osteoporosis, you will see that there is a lack of bone under the head because it's really impacted here. And to support the head, you can use substitute, as you can see here, which is a biomaterial here, but you can use, it's not really useful. Well, it's not good to use cement because it's the cement is probably it's at risk to burn the head, but we can use a graft, which is biomaterial or other type of graft, and autograft is possible. And then you will push greater and lesser tuberosity and fix here with heavy suture, as you can see, like a tension band fixations. So it's really low cost, and you will get here perfect on these X-rays, perfect fixations and perfect restoration of the anatomy. This is an example two-wheel accident, 51 years old. You will see on CT scan that you have a valgus impacted humeral head, and you will reduce it. Greater laser tuberosity out here on the X-rays, and you will push greater laser tuberosity just under the humeral head. So this X-rays results is not perfect, as you can see, because the shaft is not perfectly with still a displacement of maybe 5 to 1 centimeters related to the proximal humerus. But the greater and laser tuberosity are well fixed and in right positions. And this is the key in this particular patients. And you can see that he healed uneventfully, as you can see here. And this is a result at 3 years with a good range of motion and no pain, and very satisfied patient. He's a heavy manual worker, and he did not have any issue with his head. Of course, you can use different devices, and this one is available on the market, probably worldwide. But the problem is that how to use this kind of devices, especially with different lengths of screws. This plate, which is a proximal humeral dedicated plate, is great because it can be used to fix the humeral head and the shaft, but don't miss to fix in good position the greater tuberosity. If you have to remind something, is that the greater tuberosity, much more than the laser, but the laser as well, greater and laser tuberosity are the key point to restore function. Because on laser tuberosity, you know that you have the subscapularis muscle, and laser and greater tuberosity, you have at least 2 external rotator and the supraspinatus. So if you don't well fix greater and laser tuberosity, even if it's a very small piece of bone, it's like not repair. It's not. It's like if you would not repair a massive cuff tear. So you've got a very good bone, but and well-shaped proximal humerus, but you don't have any muscle and tendon on the bone. So you need to well fix greater and laser tuberosity as the key point of all proximal humeral fractures. Why I don't like to use plate? Because you are much more at risk to injure the small vessel around the head. And you know that one of the issue of the proximal humeral fracture is avascular necrosis. So this is a typical example here of, well, it's a 2-part displaced fracture. You know that you can see here that probably there is, even without the CT scan, that there is a fracture line between the greater tuberosity and humeral head, but it's not displaced. So we did just a fixation with this plate and screws, which are not really thin, probably too big, but it's what it was available at this time. And unfortunately, we get avascular necrosis here of the proximal humerus. If available, you can use this kind of devices, which are a nail. So it's nail dedicated for proximal humerus. It's not the same that you use for proximal femoral fracture or tibial fracture, for example. I would show you that you have to keep in mind that these nails are good to fix the head and the shaft, but are not always good to fix greater and laser tuberosity. So in the same way, be aware that you well fix greater and laser tuberosity. It's not the same question that you when you treat proximal femoral fractures, proximal femoral fractures, because you want to fix the the head and the shaft. In case of proximal humeral fracture, keep in mind one more time that you have to fix greater and lesser tuberosity. Another example here where we use a nail. So it's possible on this 3D CT scan, you can see that there is a various displacement of the humeral head related to the shaft. There is a combination here on lesser and greater tuberosity, but there are not, well, they're in good position related to the humeral head, and we just fix here with this nail and different screws to stabilize the proximal humerus. Other option is possible when you have a huge osteoporosis and elderly patient is to use a replacement, but probably that today it's not really the question. You can see that you can use hemiarthroplasty, which is available in Europe, but nowadays we prefer to use a reverse replacement because it's probably more efficient and more reliable. Even if you have even if we report much more failure and probably complication, as you can see here. So if there is a question I can answer, I have two from rope supply. 2 points from bomb blast injury.
Yes, you can answer after your lecture. Yes.
Sorry?
Tu peux continuer et on,
Okay.
et on fait les questions à la fin.
Okay. So we're going to move to humeral shaft fractures. I think that humeral shaft fracture is another well, it's another point that that you will share. There is two clinical hot points. It's vascular injury in conjunction with the humeral shaft, and the other one is neurologic neurologic injury, especially with the radial nerve. Because even if you don't have a huge displacement of the shaft, you can get in some situation a radial nerve palsy. There is different type of fracture, and you know that you can have with direct trauma here strict simple fracture, from simple to really communicative here, and you know that there is anatomical well, there is a proximity between the shaft and the radial nerve. So be aware that in pre-op you have or you don't have, donc you have to check the radial nerve in each cases you will meet. Sorry, because I have a problem here. So how to deal with this radial nerve? First, to identify the radial nerve palsy, and you know that the radial nerve is the nerve of the extension. So if you don't have to, if you don't have an extension of the finger, or if you have an hypoesthesia of the first, as you can see here on the draw, in between the first and second finger, you know, on the dorsal, that there is a radial nerve palsy. Even if you don't have a very complex fracture, as you can see here, you can find that. So it's important to identify in pre-op. If we have in pre-op, if we have a pre-op a radial nerve palsy, it's quite different approach. What are the options facing a humeral shaft fracture? You can use a non-operative treatment. Even in Europe, in some university center, we don't operate these patients. It's not in what we are doing in Toulouse when I'm working, but I know that in some center they just use this hanging cast even if you have a displacement in between 19 and 19 degrees, it's okay, it's not a big deal. You will have a malunion of the shaft, but it's really well tolerated by the patient. You will even in this situation, we will get a good functional results. The problem is that the tolerance of this kind of shaft or this kind of cast, because it's needed to immobilize the patient between 4 and 5 weeks, which is really long. And in Europe, it's not really well accepted by the patient to be in a cast during this long period, in long time. But it's possible if the patient is with a single fracture, if it's not a community fracture, and if the patient is agreed to be immobilized between 4 and 5 weeks. So this the patients the first option you can propose. The second one is to fix the patients to fix the shaft the fracture with internal fixation or percutaneous nail or pin. If it's available, like you can use in children, especially if the patient is a polytrauma patient, or if the fracture is complex, in case of open fracture, and in my according to me, and if you have a radial nerve palsy. If you have a radial nerve palsy in pre-op, I don't speak of post-op, it's I think it's much more important to fix the fracture, because the radial nerve can be inside the fracture, so you have to reduce it to release the nerve and to identify the nerve is really injured or just stretch. And then fix the fracture with pin, plate, or nail. It's depend of what is available in your box. If the fracture is not an open fracture, and if the patient don't have in pre-op radial nerve palsy, well, you should keep in mind that in post-op, you fix it, the rate of post-operative radial nerve palsy is 10%. So if you don't have in radial nerve palsy in pre-op, unfortunately, you will get a risk of 10% of post-op radial nerve palsy. Is radial nerve palsy an issue? It's not a big issue. If is only a stretch of the nerve, it will take between 3 and 4 months to recover if there is only a small stretch. But if you have a much more a bigger injury of the nerve, you can have a definitive radial nerve palsy, and the problem will have to get to do secondary surgery of the finger to with transposition, for example, of tendon to recover extension of the finger. So this is an example where we had a radial nerve palsy and displacement of the shaft, and we decided to release the nerve first and to fix the patient with plate and screws, as you can see here. And this is the example of the that I wanted to show you. This is another one here, and in this situation we decided to use a nail. So this fracture is not really there is not really a big displacement of the fracture, and probably that we could use just a cast, an hanging cast, just to maintain the shaft, the fracture of the shaft here. But if you look at the X-rays, you can see that there is here another fracture of proximal humerus. So that's why we decided, because it's really unstable, to fix with a nail. and this nail can fix the proximal part of the humerus and the distal part, and it's more comfortable for the patients to be stabilized in this manner. This is an example of a very of an elderly patient who had this the displacement is not big, but there is between 1 and 2 centimeters of displacement, and the patient were really frail patients. So we decided to use a hanging cast, as you can see here, and it's really well reduced, and the patient accepted to be to accept this cast, and we eventfully get healing of the proximal of this shaft fracture. The other option are pinning. As you can see here, it's really interesting to use pinning. And before having in our boxes nail, we use only pin. So the entry point is at the elbow level, and you have to fill the shaft with pin, whatever the diameter of the pin, but you have to fill it, and it's stable because you fill, which, I don't know, maybe 5, 6 or more pin inside the shaft, just to create this stabilization. So you use C-arm and you push the pin inside the shaft. The other option is to use an X-fix. In our hands, it's only if you have a very bad wound with a gunshot fracture, for example, and we prefer to use a pin. We prefer to use an X-fix first, and if the skin is good, we can convert from an X-fix and switch to a pinning or nail, for example. But in our hands, it's only for this situation. The other situation in when you have a vascular injury and you have to quickly fix the shaft before revascular the hyperlimb. So we use an X-fix quickly and ask to vascular surgeon to do the job as fast as he can. This is another example. Here you can see that at the beginning we had a gunshot fracture, so we use an X-fix, but there is a really big bone loss at the medial shaft part. So because the patient had just a good recovery in post-op, we put a piece of cement here, and we used what we call a masquerade technique. The masquerade technique is really useful because if you have a bone defect, as you can see here, at 3 months, if everything is good, you can put a graft and a plate, and you will get, as you can see here, very good healing of the shaft. What would be the other option is to shorten the shaft. It's possible if you have a bone defect, you can shorten, but you cannot shorten much more than between 1 and 1.5 centimeters. So in this situation, we had more than 3 centimeters of bone defect. So that's why we decided to use this masquerade technique. So the first step is to use an X-fix and a piece of cement. Then you will get a good healing of the wound around and the skin and the muscle, and everything is okay. And at 3 months, you graft the patient and you put a plate, and you will get this kind of post-op evolution with a good healing. It's really useful. Now we're going to move to olecranon fractures. Olecranon fractures are really frequent. It's more or less always a fall on the hand, but much more always a fall on directly on the elbow. And the problem is that the olecranon end is just under the skin, and under the skin, you know that you are at risk to have an open fracture, a skin injury. So it's painful for sure. It's swelling. There is more or less a big hematoma, and the biomechanical problem is that this proximal part of the olecranon is pulled by the triceps and is at risk to be displaced. The CT scan is not always necessary if you have a simple and non-complex fractures. But what is interesting is that with a CT scan, you can be sure that there is no associated fracture, especially with the radial head. So if the fracture is undisplaced, maybe you can use a cast, but you know that the triceps is pulling on the olecranon, so it's necessary to use a cast in slight external rotation, in slight extension, with 45 degrees of extension, just to counteract the pulling forces on the of the triceps. The other option, if the fracture is displaced, is to use K-wire and a tension band here with as you can see here, it's more, in my hands, it's more stable if the K-wire are from the proximal olecranon into the anterior cortex of the olecranon and not inside the shaft, as you can see here in this X-rays. So I think it's more stable. It's different from biomechanical point of view. This an AO concept, or but you can put the K-wire inside the shaft, but it's better if you fix the K-wire in the anterior cortex here. And it's stable, and more the patient will flex the elbow, more compression forces you will get inside the fracture. So it's good. It's good, but there is of course different situations when the fracture is complex, as you can see here, because in this second situation you have a bad fracture and complex fracture, but you can see that you have elbow dislocation associated. So when you have elbow dislocation associated to the olecranon fracture, you cannot use a soft fixation, as you can see here. It's necessary to use a very strong one and a plate just to counteract the force of dislocations. So if you use K-wire, it will bend it for sure, and you will have a recurrence. You will get a recurrence of elbow dislocation. So you need to have a plate if the elbow is dislocated, associated with olecranon fractures. Now, if we look at the question of elbow dislocations, the elbow dislocations is much more in posterior-lateral dislocations. Not always the case, but it's what is the most frequent. When you have elbow dislocation, you know that the X-rays is enough to diagnose the dislocation, and you have to reduce it with direct manipulations on the elbow. If it's better to use local regional anesthesia or general anesthesia if necessary, with direct pressures. What I just have to say, because you have ever in your practice reduce elbow, is that you have to test the elbow. When you reduce it, test it, because the issue is to have an unstable elbow. If you have an unstable elbow, it means that if you extend your elbow, you will find that dislocation recurred. So if it extends at less than 45 degrees and you have recur dislocations, it means that your elbow is unstable. So do testing now, not in supination, but in a pronation. And if you tested one more time in pronation and the elbow is stable, it's okay. Just immobilize in a cast during 3 weeks. But if you are still unstable at less than 45 degrees of extension, it means that you have a big injury of ligaments, and especially with lateral collateral ligament and probably medial as well. So in my hands, when I reduce an elbow, I test it. If it's stable in full extension, I just put the elbow in a sling and ask the patient to get the sling to wear the sling during 3 weeks and not a cast. If it's unstable in extension and pronation, I just put a cast during 3 weeks in 90 degrees, as you can see here, and in full pronation, because it will stabilize and just be efficient to get healing of 2 ligaments. But if it's still unstable, I used to fix the 2 ligaments in an emergency, more or less emergency setting, just to be sure that the elbow will be stable over time. X-rays is efficient. It's very rare to have a vascular and neurologic injury, even if it's described in the literature, but you have to be sure that there is no injuries after the reduction of the elbow. Now, if we move to radial head fracture, I will just show you that this small piece of bone can be a big issue in pronosupination at long-term follow-up. And you know probably the Mason classification that describe all these situations, which is a simple fracture with an undisplaced fracture. An undisplaced fracture is less than 2 millimeters on X-rays. So small displacement, it's type 1 and type 2. And if you have a different fragment, as you can see here, it's type 3. Even if you have a radial neck fracture, which is type 4, but it's not so frequent. If you have a small displacement, probably that in this case, you can see here on X-rays, we could probably treat this patient non-operatively, but the surgeon decided to fix it. We use much more screws than pin, but it's possible to use pin. Yes, I said that because there is a minimal displacement, and I'm not sure that there is much more than one or 2 millimeters. So if it's less than 2 millimeters, just treat it non-operatively. What it means that you put the patient not in a cast, but in a sling, because you know that in a sling, he can mobilize the elbow small, but he can mobilize with small self-rehab motions. So it's good for only 3 weeks. I never seen any displacement of the radial head fracture when I put the patient in a sling, provided that the elbow is stable. But there is another fixation, which is the terrible triad, which is the association between radial head fracture, coronoid fracture, and ligament injury during elbow dislocations. This is a typical example here of a terrible triad of the elbow. It was described by Hotchkiss in 1996. And this situation is quite different because we have elbow dislocation associated with radial head fractures. So it's quite different because even if the elbow reduces, it will be for sure unstable. And you know that the stability of the elbow, it's in 99%, in 50% thanks to the bone, but is 50% thanks to the ligament. And the coronoid fracture, for example, even with a small piece of bone, less than 50% of the coronoid will be at risk to create an instability. So if you have an association with elbow dislocation, coronoid fracture, and radial head fracture, you have to keep in mind that there is a high risk of post-op instability, even if you reduce the patients, especially because the coronoid fracture will be the rule of 50% is quite good because the coronoid fracture is really important to elbow stability in anterior posterior directions. So it's an example where we well fix the ligament, as you can see, because there is some anchor in the bone, but we never fix the coronoid fracture, and we had a recurrence of the elbow dislocations. Another example here, we just removed the humeral head. It's not good. It's not good because you have a valgus instability in this situation. So every single points are important to have a elbow stable. I mean that the coronoid is important, a radial head is important. So in this situation, we decided, because it was removed, to use a prosthesis to stabilize in valgus the elbow. So the elbow is stable because he had a good coronoid and he has a radial head and the ligament we'll see in few minutes. So in these other situations, we don't have a big fracture of the radial head, just a small piece of cartilage and bone, and we only fix the coronoid with a medial approach, and the elbow was stable. Another example here with a cerebral triad, and we decided to fix the coronoid fracture with lag screws, and to fix the radial head with screws or pin. We could use pin, but we use screws in these situations. The stability of the elbow is really important, and it's really because we have first the coronoid, second the ligament, collateral medial lateral ligament, third the medial ligament, in 4 we have the radial head, and 5 the olecranon. So it was proposed this single draw, a simple draw, where you can understand that the coronoid is really important to stabilize the elbow. So be aware that the coronoid is well fixed. Another example of cerebral triad, we just reduce first the patient. We get a 3D CT scan, and then we decided to operate these patients. How can we imagine, or how can we find, we can identify a cerebral triad? First step, as you can see here, is to look at the patient, and if in medial, as you can see here, you have a big hematoma, it's because probably you have a medial injury of the ligament. So be aware that in post-op, when you reduce your elbow, you will have a good restoration of the anatomy. In situation, for example, we reduce, but we knew before that we have a radial head fracture at the level of the neck, and of course it's not we need to fix it. We just fix it afterwards. Another example here. With a bad injury of the elbow, we can see on the CT scans that we have a small piece of bone, the coronoid fracture, but this is for sure a terrible triad, and we have a bad fracture here on the proximal radial radius. So in this situation, for example, if you cannot get a good open reduction and internal fixation of the radial head, if it's available, I know that it's not always available, we should use a prosthesis just to be sure that the radial head is reconstructed, because if you don't reconstruct the radial head, we'll have valgus elbow instability. So it's not possible. You will have to put something to stabilize in lateral your elbow. Some example here where probably the last case that we cannot where the elbow was stable and it was still stable at forward, but it's really rare to have a stable even if we have this fracture of the coronary. You can test the elbow on as you can see here on the C-arm, and you can see that the elbow in stable in extension. So it's very rare to have a stable. If you get on fluoroscopy, maybe you can just use a cast, but it's very rare, and more or less you have to fix the coronary, you have to fix the radial head, and to fix the lateral collateral ligament. So as you can see here, we thought that it wasn't stable, and we see on post-op X-ray that the instability recurred, and so we stabilized the patients. Another example where the radial was bad fractures, and we decided to operate it. So that's it. Just to show you some picture how to fix it. We can have a lateral approach here, and if you have a lateral approach, you will find that there is nothing inserted on the lateral epicondyle just because the muscle are detached, as well as the lateral collateral ligament. So if you open the skin, you will find directly the joint, and this the proof that there is an injury of lateral collateral ligament. So we need first to fix the coronoid process, then to fix the radial head, and before closing the skin, reinsert with anchors if there is available anchors on your back table, or with a transosseous suture with very simple fashion, fix whole here the muscles and the lateral collateral ligament at the back. So it's very important to repair the lateral collateral ligament to get a stability of the elbow. The radial head can be fixed or replaced, but never remove the radial head. This is what you probably have to remind, that if you have a terrible triad and if we resect the radial head, it's too bad. You will get a recurrence of the elbow instability. So fix the radial head and fix or replace it, and fix the coronary process and repair the lateral collateral ligament. Even with small screws, it's much better than to remove it. And this is example of these patients. Another example here where we replace the radial head, but you will see that it's not always good. Why? Because I know the surgeon who did that, and I know that he never fixed the lateral collateral ligament first, and it was still unstable. So he decided, like he did with hip, to put a bigger head in order to overtension the elbow and to get better stability. I know that it's a too big head and too high head. Why? Because if you look at the line of the articular, line, you can see that the distance between here the humerus and the ulna is different in medial and lateral. It means that here the lateral compartment is in overtension because the head is too high. So he wanted to absolutely get elbow stability. So he overtensioned the lateral compartment with the radial replacement, and he unfortunately had recurrent instability. So we decided to use an X-fix, not to change the radial head, to just put an X-fix to stabilize and to repair, of course, the lateral collateral ligament. So this is an example. Here, a different example of coronoid fracture, which is a small piece of bone, but we need to fix it. We can, in type 1 or 2, which is small fragment, not to braid it, but if you have a type 2 or 3, if you get an access for lateral approach, it's possible. But if you don't have a good access in lateral, you have to use in medial. So a medial approach, it's better to fix with screws or plates, small plates, the coronoid process. You can see here on these pictures that you have a coronoid process here, and you can use screws. You can use different type of fixation, and if the patient is still unstable after coronoid fixation, coronoid fixation, radial head fixation, and lateral collateral ligament repair, don't hesitate to use an X-fix during 3 to 4 weeks, just to be sure that the elbow is still in place and you will be safe. Some kind of prostheses are described, but they are not really available on the market. So here we are. I'm sorry, but we are at 7:45, so I will stop at this step. So
Yes.
any questions?
Yes, thank you, Nicolas. You will have some question now, and you can answer. And after, we will continue in some weeks for the other part for distal fracture of